Và sau đây chúng ta sẽ tiếp tục với báo cáo viên tiếp theo, giáo sư Leroy Romanik, và chuyên khoa về can thiệp điện quang và mạch máu ở bệnh viện François Mitterrand ở vùng Dijon của Pháp. Giáo sư có rất nhiều kinh nghiệm trong việc đặc biệt là làm những cái can thiệp ngoại biên và có những cái bài báo xuất bản trên các tạp chí quốc tế. Và cái chủ đề của giáo sư là sử dụng các cái vật liệu nút mạch dạng dung dịch để điều trị các cái xuất huyết tiêu hóa.
Thank you very much for invitation. It's a great pleasure to be part of this. So, in this session, I will have two talks, and the first one is about percutaneous creation of arteriovenous fistula for hemodialysis. So, let me show you our experience about that. So, first of all, let me remind you some very simple things about arteriovenous fistula for hemodialysis access. You know better than me that the goal is to obtain a superficial vein with sufficient flow in order to allow dialysis. Usually we use surgery for this to connect a vein to a closed artery in the forearm or arm usually, and part of the arterial flow will be diverted into the arterialized vein. Of course, with pressure increase and dilation, the goal is to get sufficient blood flow and to facilitate puncture. And we need the flow of at least 600 milliliters per minute with a vein diameter at least 6 millimeter and maximal depth 6 millimeter. Otherwise, it can be difficult to puncture, and we need ultrasound. So usually, as I said before, this is performed by surgery under local regional anesthesia as an ambulatory procedure, or in a patient who is hospitalized, and we need at least 6 to 8 weeks to get maturation for before dialysis, of course, and sometimes we need a second intervention if the vein is too deep, which is called superficialization of the vein in a second step. So some rules and principles with fistulas is that we have as much as possible to use a distal radiocephalic arteriovenous fistula. It should be the first choice because in terms of patency, we know that this is the best option for long-term patency, but this is impossible or at risk of lack of maturation in up to 30% of patients for many reasons. For vascular condition, for calcifications, because of diabetic patients, polyvascular patients, making potential anastomosis between the artery and the vein quite difficult and at risk. So the second choice would be in that case humerobasilic or humerocephalic brachial arteriovenous fistula, usually in 2 steps, but we know that the long-term patency is lower, with some potential complications like Steele syndrome, aneurysm, making this option as a second option. So is there a role for radiocephalic proximal arteriovenous fistula, which is between both? Yes, with the creation of percutaneous fistula under ultrasound, I will show you. So the goal of our study was, of course, to assess the feasibility, safety, and efficacy of percutaneous arteriovenous fistula creation for hemodialysis access with the thermal resistance anastomosis ellipsis device, which is a specific device, as you can see here, with a small generator, as you can see on the left side, and a needle that we connect to the generator. This is usually made under ultrasound. We don't need any X-rays. With very simple things, a 5 French small sheath, and then everything is made in the lab, but under ultrasound, as you can see here. And we need to know by heart the anatomy in the band of the elbow, which is a very specific anatomy, and you know that we have the perforating vein, as you can see here, which is connecting the superficial and the deep venous system. The basilic is giving the medial basilic vein, the cephalic, the median cephalic vein, and from that point, the perforating vein makes communication between the superficial and the deep venous system, and the proximal radial artery is just close to this perforating vein, and this is the target to reach in that case by endovascular approach. I will show you. So we usually make this kind of procedure under local anesthesia, or mainly now with axillary block. This is preferable for two things, because we get vasoplegia, and the veins and the arteries are bigger in that case, which makes the procedure easier. The goal is to puncture the cephalic vein, as you can see on the sagittal view, by ultrasound with a 20 gauge needle at the elbow, crease under ultrasound guidance, as you can see here. And this is the perforating vein, and then the proximal radial artery. And we have to navigate with the metallic needle into the median cephalic vein and perforating vein, and at that level to puncture, as you can see on this picture, the tip of the needle to puncture from that point the proximal radial artery, which is very easy under ultrasound, especially after vasoplegia. And you can see here from the vein to the artery. Then in that case, we have to insert a small guide wire, or 40-inch guide wire. And then on this guide wire, we can put 6 French sheath from the venous side to the arterial side, and we put the sheath in the artery to make the first hole, I would say, which is very important for the rest of the procedure. And then we insert into the sheath the needle with two thermal components deployed under ultrasound guidance. You can see on this picture the two components which are very easy to see under ultrasound. One deployed in the artery and one in the vein, and you can see the window between both. And then we have to bring closer the window. Normally this is 7 millimeter, and we need not 0, but at least 1 or 2 millimeter to be able to close it and to close this window and to bring closer the wall of vein and the artery. And then we can apply thermal energy, which is a cycle of several seconds, let's say 15, 20 seconds, very short, to make the anastomosis between artery and vein by thermofusion. And then the arteriovenous fistula is created, and you have to jump to withdraw the device. Let me show you this very quickly with a video, a specific video. So the device Ellipsis was initially made by a startup, Avenue Medical. It has been bought now by Medtronic. So we have to puncture under ultrasound the vein, and then pass through the medial cephalic vein, the perforating, and to puncture the proximal radial artery. And then you insert the sheath on that, which is something easy. So you can do it by axial approach or sagittal approach under ultrasound. It's up to you. You can do both. And then on the guide wire, we insert the needle. You can see the window that you have to insert closed, and then you open it after that. And then you remove a little bit the sheath, even completely, and then the two components are one in the artery and one in the vein, and you bring them closer to close the window, and then to be able on the generator to apply thermal energy and get creation of the arteriovenous fistula. So this is very easy to do, I would say. This is the first step. Now, in addition to this procedure during the same intervention, we systematically do balloon dilation with a 5 millimeter in diameter balloon to accelerate maturation of the fistula and to get earlier use. As you can see here, you can do it under ultrasound. We see the balloon very well here to dilate the anastomosis immediately. There is no risk of hematoma or complication. You can do it without any X-ray. It has been modified, this technique, by my friend Alexandros Malios, who is the pioneer for this technique. And this is the final control, and you can see under ultrasound the connection between the vein and the artery and the fistula that you can see here. So this is the technique, and so we performed, we analyzed our experience with 25 patients over the last 3 years under local general anesthesia with this device. So as you can see here, mainly Caucasian patients. Of course, most of them had no catheter dialysis before and no previous arteriovenous fistula before. So it was a first one in the majority of patients, mainly on the left. We did the first 3 patients under local anesthesia, but honestly, this is really better under regional block and regional anesthesia to get vasoplegia. No contrast, no X-rays, and angioplasty of the anastomosis all the time now during the intervention to avoid postponed dilation of the anastomosis, because the stenosis, of course, is the main potential complication. So for all patients, as you can see here, you can see the blood flow at follow-up, ranging from very small and immature in 2 patients up to more than 1 liter per minute, which is very interesting, and with no re-intervention in most of cases. And every time we got re-intervention, it was mainly anastomosis PTA. So 100% in terms of technical success. Cumulative patency at mean follow-up, 96%, very high. Average blood flow at mean follow-up, more than 800 milliliter per minute, as you can see, which is quite interesting after almost 20 months of follow-up. Re-intervention during follow-up in 6 patients, mainly PTA of the anastomosis, and in 1 patient, basilic vein embolization. Sometimes we can have to embolize some collaterals to redirect the flow. No readmission, no complications at all, thrombosis, hematoma, nothing about that. Just anastomosis, stenosis, and the mean cannulation time, as you can see, 6 weeks. And the type of cannulation, normal or Y, with no mortality, of course. So you can see on this picture the kind of cannulation we can get, a normal one or a Y one on both veins. And when we have to do angiography for this kind of patient, it can be very challenging, because the anatomy is very special here by radial approach during follow-up, and you can see the stenotic lesion at the anastomotic level here. And we decided to, in that case, to put a plug in the basilic vein, as you can see, to get a huge and big cephalic one, and then to do angioplasty and stenting of the anastomosis. And this is the final result. And this is one of the first patients we did who is still patent, with a good flow in the fistula. And you see the specific anastomosis you have between the proximal radial artery and the cephalic vein in that case. So, of course, some papers now in the literature about this technique as compared to surgery. We have no scare. This is still a radiocephalic fistula, not humerobasilic fistula, so which is supposed to be better in terms of long-term patency, with immediate adequate blood flow after anastomosis dilation. No incision care again. This is a low flow and low pressure fistula. which is very interesting to avoid long-term complications of normal fistula with potentially a lower rate of complications. So if we look at the literature and the first pivotal multicenter trial in the US, among 261 patients, only half of them, even less than half of them, were finally treated, meaning that there is a selection that you have to make by ultrasound. You have to do it by yourself to make sure that the patient is a good candidate for that. But in our experience, of course, we did less patients, but this is almost 90% of patients. You can try the left or the right, but you have to select the patients to make sure that the anatomy is favorable for this. And you can see the flow in the fistula from the procedure to 1 year up to 1 liter per minute. And the main complications at the initially in the first papers was, of course, the need for embolization of some collaterals and angioplasty of the anastomosis. As you can see here, up to 22% of patients. That's why now we do it directly during the first session and the first intervention. And this is the kind of cumulative and functional patency you can get, which are very high, of course. And if we look at the biggest series from Alexandros Mayos, it has been published last year, about 205 patients, 99% of technical sepsis after mean follow-up of 11 months. You can see the primary patency, primary assisted patency, and secondary patency rates, 65, 88, and 97, with no serious adverse events, a mean access flow of 874 milliliter per minute, no Steele syndrome on the long term, very important and very interesting. Only 7% of patients needed a secondary superficialization, and average maturation time only 4 weeks, which is very interesting, with 10% of patients with early cannulation, meaning less than 2 weeks, which makes this intervention very interesting. So in conclusion, I would say that percutaneous arteriovenous fistula creation with the ellipsis device is feasible, very safe, efficient for giving prompt functional vascular access for hemodialysis. This is minimally invasive. This is a one-step confection. This is a very fast procedure under ultrasound. You don't need any X-rays or contrast. It's less than 20 minutes now to do this. You make a low pressure arteriovenous fistula, which is very interesting to avoid the long-term risk of complications of normal fistula because of high flow. In that case, this is a low flow, which is very interesting. This is less unsightly for the patient, and you can really get earlier maturation and cannulation as compared to normal surgical fistula, with less complications, as I said before, such as aneurysm or Steele syndrome, which can be very interesting, and with a high rate of satisfaction for the patient, of course. You can see the kind of fistula you can get with the device as compared to some very high flow fistula with surgery. Of course, you need the specific education of nurses and nephrologists, because this is the kind of fistula you have to puncture under ultrasound sometimes, and you have to pay attention that this is not too much deep to avoid this, but it can be very interesting in very selected patients as a second choice if distal radiocephalic fistula is not possible surgically. Thank you very much for your attention.